she was killed somewhere from Skyrim. Pô, que susto que eu Skyrim, que susto
Good afternoon, everyone. Can everyone have a seat, please? And we'll go ahead and get started with our presentation. Hello. Hi, everybody. We're going to get started with our presentation. Welcome to the Southern Blood Cancer Conference Multiple Myeloma session. We are excited to have you joining us back in person again this year. Due to an unfortunate family emergency, Dr. Romeo cannot join us today, but I do have the pleasure of introducing Dr. Jonathan Kaufman. Dr. Kaufman is professor. Dr. Kaufman is professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine, board certified in hematology and medical oncology. Dr. Kaufman's practice includes treating multiple myeloma and amyloidosis patients at Emory University Hospital. As a network physician, he has started practicing with Emory in 2005, and he's also active in clinical and translational research in the fields of multiple myeloma, amyloidosis, and bone marrow transplantation. Dr. Kaufman is a member of the Discovery and Developmental Therapeutics Research Program at Winship Cancer Institute, and he also holds memberships with American Society of Clinical Oncology and American Society of Hematology. So with that, I'll turn it over to Dr. Kaufman.
Good afternoon. I know a lot of you, and obviously my patients are the ones that are most disappointed that they don't get to hear from Dr. Lono. I appreciate the invitation, and it's always a lot of fun to talk. Today, I'm going to talk about our latest treatment, some research, some ideas that we have, and in a large part, the way that I present to patients is I'm going to share you the data just like I see the data. And we might walk through it a little bit differently, but this is the data, how we look at it. And so to get started, this is an update from a publication that was done by our entire group, led by Dr. Joseph. You see in the upper right-hand corner. You see her? Barely. Cut off a little bit. And we now 16 years ago or so used a 3-drug regimen of Revlimid, Velcade, and dexamethasone in a clinical trial, and that clinical trial had a 100% response rate, and that had never happened in myeloma before. So we then, starting as soon as the trial ended in 2007, we said, we're not going to wait until there's randomized studies that show that this is the right thing to do. Those randomized studies came out and showed it was the right thing to do. But we're going to start this today. And so this looks back at our patients over now, it's been something on the order, this data is probably 3 or 4 years old, but it shows that if we use RBD, planned transplant in most patients, and maintenance in most patients, we can have really good outcomes for patients. And you see here, if we take this entire 1,000 patients, that the average survival is more than 11 years. So that means of all these patients that we took care of, there was more likely to live, just as likely to live more than 11 years than less than 11 years. And so this was the fact that we chose regimens that were very effective. We had early transplant, which we still think is important, what we call risk-adapted maintenance, really had a major impact on survival. But it's not enough. And so we then participated, and there's the development of daratumumab, which is a monoclonal antibody that targets CD38, which is a molecule, a protein that's on myeloma cells. And this was the clinical trial that we participated in. And this is called the Griffin study. And we were the lead accruers to this national study. And what you see here is that the patients who had daratumumab added to RBD and transplant and maintenance had a better response than those patients that didn't have daratumumab. And that improved response then translated into patients staying in remission longer. Both arms are so good from a survival standpoint that there's no difference in overall survival yet, but there's a clear improvement in the depth of response and how long patients stay in remission. So when we participated in this study, we made the same exact decision. We said that this 4-drug therapy seems better than the 3-drug therapy, and so we made that our standard of care. And Dr. Joseph again went and analyzed, and now there's 325 patients, our patients, you, and asked the question, how are things going? She presented this just last couple of weeks ago at the International Myeloma Society, and showed that 90% of patients at 3 years of treatment are still in remission on this treatment, which is, when you compare historical to RBD, was 70%, and now it's 90%. And the number of patients that are alive at 4 years is 92%. In the other study, it was 82%. And so by just, in our experience, by just adding daratumumab to the 3 or 4 cycles in the beginning of therapy, 10% of patients who would have died from myeloma are alive because they had this change in therapy. So hopefully at our next meeting, the American Society of Hematology in December, we'll be able to show everybody the analysis comparing the group of patients who had RBD and the group of patients who had dara-RBD. And we think that this is now becoming the standard. So unfortunately, most patients, not everybody, will ultimately relapse from their initial therapy. And while we use dara-RBD, there's other options to use, but I think for the most part, for young and healthy patients, a 4-drug therapy is the standard, which includes components of the drugs that we used. So when we have the decision when there's relapse, and again, most patients will ultimately have relapse disease. There's a lot of decision-making that goes on in how we manage that relapse. We ask the question of how are you doing at this time? Not related to myeloma, but overall functional status. We ask what's going on with the myeloma? Is it attacking the kidneys right now? Is it attacking the bones right now? We look at the inside of the myeloma cell. We look at the myeloma biology. Is there something changed with the biology? We look at the treatment history. What have you had previously? What have you tolerated previously? What were the side effects you had from something previously? And then we ask the question of lifestyle. What is your preference? We do ask. I mean, whether we listen, it's a whole different. But we know, in all seriousness, we want to know what is your preference. And because there's a lot of times where there are 2 correct decisions medically. There's 2 things you can do. And we need to know from you, what is your preference? And that helps me. I never ask my patients to make their medical decision. That's my job. But what I do is I say, I need to know what your bias is. I have 2 things that I would be totally comfortable with, but they are delivered in a very different way. And so I need to know what your preference is, and that helps me make my best recommendations. This is a slide that shows, after putting all of this data together, we come to this slide, which is we have a lot of options. And we look at options. We say, are you refractory to Revlimid, or lenalidomide is the generic term? Are you refractory to daratumumab or Darzalex or Faspro? And that helps us make the next decision. And but what I tell, especially oncologists, is that whenever we make the first decision about what to do at relapse disease. We're actually making the first and second decision. Because we have so many options, if we choose, for example, most commonly patients are on Revlimid, and if they're progressing, whether they've had a transplant or not had a transplant, the vast majority of patients, when they progress, are progressing on Revlimid. And so we typically, broadly, we think the next line of therapy is Pomalyst or pomalidomide, which is a Revlimid-like medication that we know works when Revlimid stops working, or should we switch to the proteasome inhibitors, that's Velcade and Kyprolis. So in a large part, the big decisions are, do we do a Pomalyst-based regimen or a Kyprolis-based regimen? And then once we've made that decision, if we use Pomalyst now, and let's say we use it with Darzalex or daratumumab or isatuximab or Sarclisa, then the next time we're going to use Kyprolis. If we use Kyprolis right now, then the next time we're going to use pomalidomide. And then we're getting into so then we're starting to talk, we've had 3 lines of therapy, and then we're starting to talk about all of the new things, and I'm going to spend a good portion of my talk today talking about all the new things. So one of the things that, in terms of, this is both the things that we do now as well as research, is try to figure out in the laboratory what's appropriate, and then see if that helps patients. And so in the laboratory, our group, led by Larry Boyes and Vikas Gupta, and this was work done by Shannon Matulis, who you'll see in the next slide, we found out that a certain subset of patients, those patients who have what's called the 1114 translocation inside of their myeloma cell. It's not in their whole body, it's just the myeloma cell. And that's when a portion of the 11th chromosome was mixed and matched with a portion of the 14th chromosome. And for those patients that have that, we identified in the laboratory that they were very likely to benefit from blocking a particular protein called BCL2, and the drug that we used to block that particular protein was a drug called venetoclax. And so again, the scientists in the laboratory, and what you see in this table are patient samples. You know, when you have a bone marrow biopsy and we ask for just a little bit more so we can send to the scientist, well, this is what the scientists do with it. They look, they assess whether the cells, the myeloma cells in the test tube essentially, are sensitive to the drug. And all of these in red were sensitive to venetoclax. And a lot of these you see here, let's see if I can get this pointer to work, were a positive for this one marker. And we had one particular patient who was uniquely sensitive. This is her. She was uniquely sensitive. She participated in this study. She had an immediate and long response to therapy. And you see here, what's really cool is that this is the scientist standing next to the patient. So this is the scientist that did all the work standing next to the patient that benefited from the work. And so this is the type of thing that we're trying to do in all of myeloma. So the bigger picture of this drug is a single agent. It worked in 40% of patients who had 1114 and only 6% of patients that didn't have 1114. So that tells us several things. One, clearly 1114 is a marker that this drug is going to work, but it's 40%. So that's good for the 40%. That still leaves 60% of patients that we need to work harder for. On the other hand, it does suggest, even though it's only 6%, there is 6% of patients who don't have 1114 that really benefit from venetoclax, and that's the type of work that we're trying to figure out. We then added our best friend, everybody's best friend, dexamethasone. We added dexamethasone, and the drugs and the response rate went from 40%, depending on the patient population, it increased by 10 to 20%. So we then asked the question, can we add our newer drug? So this was a study that we actually also just presented at the International Myeloma Society the meeting, and this is looking at, actually the study that we presented was the venetoclax plus daratumumab and dexamethasone. And you see here, I had mentioned that venetoclax is a single agent 40%. it's 60% with dexamethasone, and here you see it's 90 to 95% with the 3-drug regimen. And then a significant portion of patients have a very deep response. And so we're very excited about this treatment, and so we're still working on this treatment. We also asked the question, can we combine venetoclax with carfilzomib or one of the proteasome inhibitors, Kyprolis? And again, we just presented this at the meeting. And again, when we added venetoclax to Kyprolis and dexamethasone, 90+% response rate versus 60% response rate with carfilzomib and dexamethasone alone. So we now know that we can identify a patient population that benefits from a drug, and then we can mix and match new drugs that are targeted for this particular abnormality versus the drugs that we already have and have very good outcomes. So the vast majority of the rest of this talk is going to talk about our new and old immune therapies. For probably until about from 2000 to 2015, really the only immune therapies we had were what we call the IMiDs, the immunomodulator drugs. Thalidomide, Revlimid, Pomalyst or pomalidomide. We didn't know how they worked. We did a lot of hand waving about it affects the immune system in some way, but we didn't really know. There was a time we talked about allotransplant. Allotransplant means not your own stem cells after high-dose chemotherapy, but somebody else's stem cells. The good side of allotransplant, at least, is that in theory, it can be associated with a cure. We haven't, but unfortunately, that's not what the data has demonstrated. And the data demonstrates that it's not really better than an auto transplant, the typical type of transplant we do, and it's much more dangerous. And myeloma, we started developing antibodies for cancers back in the 90s, and myeloma, a disease that makes antibodies, didn't have antibodies until approximately 10 years ago. So what do we have available to us that targets the immune system? Again, we have the IMiDs, the ones that we've been using for a long time. Thalidomide, lenalidomide, pomalidomide, actually available since the late 90s, thalidomide was. There are new thalidomide or IMiD-like drugs that we now call CELMoDs, iberdomide and zigdomide. We now, for the past 8 years, have monoclonal antibodies. Daratumumab or Darzalex or Faspro, elotuzumab or Implicity, isatuximab, Sarclisa. All of these are antibodies that bind the myeloma cell, and then some of them kill the myeloma cell directly, and some of them coordinate with and then they all coordinate with the immune system to kill the myeloma cell. Belamaf was a drug that was approved for a relatively short period of time and then taken off the market. This is a new type of drug, and we hope these types of drugs will come back, called antibody-drug conjugates. So it's an antibody, and then, as the name says, drug conjugate. There's a drug attached to the antibody. So what the antibody does is it goes directly to the myeloma cell, and it delivers chemotherapy to the myeloma cell. The reason this drug got taken off the market in a large part is because the benefit of it was not, in at least one large study, was not outweighed by the risks. And there were a lot of ocular or eye toxicity associated with Belamaf. And so the people who made Belamaf are going back to the drawing board to figure out how we can find the right population of patients and the right dosing strategy to help. Over the past several years, we now have CAR T cells, chimeric antigen receptor T cells. And I'll talk a lot about CAR T cells. We have 2 approved CAR T cells, and we have idacaptogene viclucil. Everybody can say that very easily. And we have ciltacabtagene autoleucel. For me, I call them Idacel or Ciltacel. Then the brand names are Abecma and Carvykti, which are even easier to say. We have a new target in myeloma I'll tell you about, and there's research for new targets in CAR T cell. And we'll talk CAR T cell in details in a few minutes. And then over the past year, we now have 3 bispecific antibodies. This is a new technology, a new way of delivering therapy that are now approved, and we have, again, 2 new targets we'll talk about shortly. So this is another way, this is basically the same slide, but looking at it visually. There's all these drugs that target the outside. There are 2 mAb targets, CD38. The CAR T cells and the bispecifics target things, something like proteins on the cell called BCMA or GPRC5D. And then we have the drugs on the inside, the proteasome inhibitors like Velcade and Kyprolis. We talked about venetoclax, and as well as the IMiDs. Speaking of the IMiDs, we actually know how they work now. We don't have to hand wave about they affect the immune system in some way. And so IMiDs actually, broadly speaking, target 2 things. One, they target this complicated, what's called colon ring ligase, that helps coordinate which proteins go to the nucleus and cause problems in the myeloma cell or are brought for destruction. And then by targeting in the myeloma cells associated with myeloma cell death, and then we hit the same target in the immune cells, and then we have T cell and a natural killer cell, another immune cell in our body that targets the myeloma. So again, all of these IMiDs and cell mods work in broadly speaking 2 ways: directly killing the myeloma cell, as well as activating and killing the T cells. I'm gonna skip that. And so this is the structure of, this is len is lenalidomide or Revlimid, this is pomalidomide or Pomalyst. And you see they look very, very similar structurally. And here are the 2 new drugs. Again, we know Revlimid and Pomalyst are approved drugs we have access to, and these are the drugs that are currently in development and research. This is iberdomide, and this used to have just a number, but now it has a name, mezigdomide. And you can see the Revlimid or Pomalyst-like structure here and here. And what's different about these medications are these tails that represent different activity, even though structurally they're very similar. Now, they all target the same general protein and the same complex. Now, these target somewhat differently and more potently. And we see in patients who have had prior Revlimid and prior Pomalyst that we can still see activity from these drugs, and we can combine these drugs. So I really think that these drugs are going to be part of our treatment for the next 15 to 20 years. All right, now we're starting into the really new stuff that I think is, even though we've seen improvements through the years, I think this is actually a huge step forward in targeting something called BCMA. BCMA stands for B-cell maturation antigen. The reason BCMA is such a good target is that it essentially only lives on plasma cells. And because myeloma cells are plasma cells, it's essentially on every every myeloma cell. And it is what's associated with plasma cells and myeloma cells living a long time. And so we have, again, I've mentioned this several times already, we have different ways of attacking it. We have these bispecific antibodies, we have antibody-drug conjugates, and CAR T cells. Okay. What is a CAR T cell? CAR T cells, CAR stands for chimeric antigen receptor. And so we're going to take one brief step back to our the last biology class we took, and our immune system is made up of many different components. And one of the components is called the lymphocytes. And the lymphocytes, broadly speaking, are B cells, which B cells eventually become plasma cells, and the cancer of plasma cells is myeloma, which is why we're all here right now. They become B cells, and in a large part, their job is to make antibodies. And then there's T cells, and T cells' jobs are to kill either cells that are cancer or cells that are infected. And so the chimeric antigen receptor On the outside, looks like an antibody, and in this situation, it's an antibody that targets BCMA, and on the inside, it's a T cell that activates the T cell. So what happens is, when we do CAR T cells, so this is the operations here. We collect your T cells, we send them to a laboratory, we find the active T cells, we engineer this chimeric antigen receptor, and again, I think about this very simply. On the outside, it looks like an antibody, and it grabs on to a myeloma-related protein on the myeloma cell, and on the inside, it activates T cells. And so we engineer the cells to express this chimeric antigen receptor, the CAR, and then we expand those cells. And then there's reinfusion of these cells, and then these cells' job is to find the myeloma and attack the myeloma body. So that's sort of what we're doing in the background. When you have a CAR T cell, what are you doing? First thing that happens is you do an apheresis. We do apheresis to collect stem cells, where we give growth factors for 4 or 5 days, and then collect stem cells for 1 to 4 days. When we collect T cells, we don't try to expand the T cells with growth factors. We just take the blood out, we spin it, the white blood cells rise to the top, and they're taken away to the laboratory, and the rest of the blood goes back in your body. So that's the apheresis. Then, at least currently, it takes about 4 to 6, sometimes 8 weeks for them to manufacture the CAR T cells. And then right before the reinfusion of CAR T cells, there's 3 days of chemotherapy. And again, if anybody's had a transplant, it's not, the reason we give chemotherapy before the transplant is to kill as much of the myeloma as possible. But that's a very different reason why we give chemotherapy before the CAR T cell. We give the chemotherapy before the CAR T cell because we're really trying to get the rest of your lymphocytes, your T cells, to be quiet, so that there's, it's not actual space, it's space for the new CAR T cells to come into the body, to grow, to get all the resources they need so they can kill the myeloma. So there's the infusion, which is followed by 2-week hospitalization, and I'll talk to you about that, why we do that, and then careful follow-up in the clinic. So what are the outcomes with the two CAR T cells currently? These are the studies that led to the approval, and in the dose that we have moving forward with the ide-cel in this study, 80% of the patients benefited, and you'll see that on average, if they got the right dose, then the benefit was more than 1 year. This is the other product. This is the cilta-cel product. And here, in this study, designed a little bit differently, not the exact same patient population, I tried my hardest not to compare these head-to-head. It would be great if we had a head-to-head comparison, so we could say which one is better. But again, we don't, and so we have to, but this is the data we have. In this study, almost everybody responded. The response rate was 97 and 98%. And if you look at their most recent update, the benefit, how long the myeloma stayed in remission, was almost 3 years. So this is really exciting for when patients have had 3 or 4 different lines of therapy, that we can get potentially up to 3 years of benefit and beyond. The reason we hospitalize and keep such a close eye on patients is because there are unique side effects associated with CAR T cells. And these are the common ones: cytokine release syndrome. And again, cytokine release syndrome and the neurologic toxicity are related to overactivation of the immune system. We are putting in countless cells into the immune system and asking them to be activated so they can kill the myeloma. Sometimes there's overactivation of the immune system, and cytokine release syndrome, or we'll say CRS, manifests as fever in the most common form of it, and then as it gets more serious or more dangerous, low blood pressure, low oxygen, and then it can, and so those are common. 80 to 90% of patients will have some sort of CRS. And depending on the product, whether it's the ide-cel or cilta-cel, is when that occurs. And sometimes it's even more serious, and people have to go to the intensive care unit. There's also neurologic toxicity that I think we understand a little bit less than we understand cytokine release syndrome, but neurologic toxicity is much less common. Can be as simple as a change in handwriting, a little bit of forgetfulness, but can be, and again, it's rare, but can be as serious as seizures and coma. So the rates of any type of neurologic toxicity, we call it ICANS, is somewhere around 1 in 5 patients, 1 in 5 to 1 in 4, and the rates of serious neurologic toxicity, it happens in under 5% of patients. There's also low blood counts. Part of that's due to the chemotherapy, but part of it's due to the overactive immune system. An overactive immune system, for reasons I don't think we understand well, will lower the blood counts. And very importantly, and this is important for every drug that we use that targets plasma cells primarily, and all of these drugs target plasma cells, not uniquely myeloma cells. The reason it works in myeloma is because these are plasma cells. And so if you knock out plasma cells, whose job in life is to make antibodies, and antibodies help us fight and prevent infections, if we knock out the normal plasma cells, then your normal antibodies will be low and you'll be at risk for infections. And so, not only the low blood counts, people think about, I have risk of infection because my white blood cell count is low. This is risk of infection because your immunoglobulins are low. And one of the standard things we do that we've learned both with CAR T cells and with bispecifics, that if we infuse something, pooled immunoglobulins from healthy donors, what we call IVIG, intravenous immunoglobulin, then we can decrease the risk of infection significantly, and that's what we do. So one of the downsides of our current approaches is that it takes 4 to 8 weeks for manufacturing. And so one of the opportunities for improvement is to shorten that time frame. And now we have a study that's currently open and accruing at Emory, where we can get the product in a week. So instead of waiting a month and the myeloma is not under control, we can turn this around in a week. So we're very excited about the updates in CAR T cells, particularly this one's exciting, but again, very early on in its research development. Okay, I mentioned bispecifics or bispecific T cell engagers, and again, I just try to simplify this because this is how I understand it, and I need to understand it in a simple way for me to explain it and understand it. On one side of the antibody, this is what a normal antibody looks like. On one side of the antibody, it binds the myeloma cells, and we can have different targets. And again, we talked about BCMA. The first 2 drugs that were approved were BCMA targeted therapies. And so it binds BCMA. On the other side, it binds the T cells. Remember, we just talked about T cells. With CAR T cells, we remove the T cells, engineer them to recognize the myeloma. Bispecifics grabs the myeloma on one side, grabs the T cell on the other side, activates the T cell, brings them together, and then the T cell kills the myeloma cell. So that's how the bispecifics work. So we now have 2 approved bispecific antibodies. We have one called teclistamab and one called elranatamab. In a large part, they're very similar. Similar benefit, somewhere around 2 out of 3 patients benefit. When they benefit, when they have a response, the responses are usually deep responses, and on average, those responses last between 18 months and 2 years. And so, while again, we have nothing head-to-head, this looks very much like the benefit that one would get from CAR T cells. Side effects are similar. We have CRS, that is common. It is less, the neurologic toxicities happen, but less likely. Infections are also of concern, that's why we use IVIG. Low blood counts are also a concern, and we keep a close eye on things. So again, now we have two things. I just mentioned this. The common side effects are the CRS, very similar to CAR T. Neurologic toxicity, similar CAR T, but less frequent. Low blood counts, and infections. And we have for patients getting these medications, entire programs to make sure that we monitor and prevent an early treatment of infections. We have a new target. I mentioned BCMA. Now we have the most recent target, and I want to say that this drug was approved the drug that hits this target was a month ago. And so this is a real mouthful. G protein coupled receptor family C group 5 member D. Okay? There's a test later. There is a test. Okay. We call it GPRC5D. That's still a mouthful. You could just call it 5D. So this was identified. It's on plasma cells, but it's on more myeloma cells than normal plasma cells. And that's a really good thing. So what that means is that we can use somewhat of a lower dose of the drug, and that lower dose of the drug still kills the myeloma cells, but leaves the plasma cells alone. And so one would predict, and it's borne out, that while we still have infection, it's less of a problem. Now, the downside of targeting, and I remember when I talked about BCMA, I said this is the ideal target because it's only on plasma cells. On the contrast, I'm going for my sake, I'm just going to call this 5D. So 5D lives on other cells. They live in our hair, in our nails, in our mouth, in our throat, and so one could predict the potential side effects from this. And so this was the study. The drug is called talquetamab. The makers of talquetamab mispronounced their own drug, and they call it talquetamab, but that's too hard for me, so I've renamed it for myself and others, talquetamab, because it seems easier. There's two different dosing strategies, weekly, every other week, but what you see here is that the response rate is in the 70 to 75% range. Those patients who had prior CAR T cells or BCMA, it's a little bit lower. But if you respond for about a year. So we're excited about this. But again, I mentioned we predicted different toxicities. There's infections, but it's less than what we saw with BCMA. But we have all this other stuff. Dysgeusia. Dysgeusia is what nobody wants. That's the awful taste in your mouth, whether it's everything tastes bad or it's metallic. So this drug causes dysgeusia in about 3/4 of patients. So it's something that we have to work around. Rash is a possibility. Nail changes. So all of these are important things that don't happen with the other bispecifics, but the more we use the medication, and we've just got to prove, the more we are able to manage it. So this is what we have today, just sort of comparing CAR T cells versus bispecifics. These are for patients who've had all their initial therapy. They've had 2 or 3 or 4 or 5 other therapies, and now we're here. So we have Abecma, Carvykti, we have teclistamab, elranatamab, and talquetamab. I think, I didn't make this slide, but I think in my mind, the efficacy is essentially the same. Has never been compared head to head, but essentially the same. What's unique about CAR T cells, and I haven't really emphasize it, is you get your treatment and then you're done. You get your treatment and you recover, and you spend how long without any treatment? A while. A year, 2 years, 3 years, more. Bispecifics is like all the other therapy that we give, which is every week, and then we drop it to every other week, and then we drop it to once a month. It's still good, but the unique benefit we see from CAR T cells is you do it and you're done. And whereas teclistamab and all these other bispecifics, we have to continue doing it. CAR T cells are likely to stay at large centers like us. Bispecifics are very much, we are in the process of developing bispecific protocols that can be treated, patients can be treated in the community, and I think that's really good for myeloma patients. Adverse events are similar. Cytokine release is probably a little bit more common in the CAR T cells and the bispecifics. It's definitely more common with neurotoxicity is definitely more common in CAR T cells and bispecifics. And then finally, availability. Again, remember we talked about CAR T cell. The really good thing is that one and done nature of it. The downside is if you make the decision today that I'm going to get a CAR T cell, you have to have an evaluation to make sure it's safe, and then you have to get the collectin, and they have to approve, and then you have to get the lymphodepleting chemotherapy, and then you have to be hospitalized. If I make the decision to give you bispecific, we schedule your treatment for next week. So that's a huge difference. So there's less sort of what I call cost up front, which is we're getting this now, but there's more cost later because it's ongoing therapy. There's a lot of reasons that these medications either don't work primarily, again, they still don't work in everybody, or that patients relapse, because unfortunately with these medications I have not shown you a cure yet. And we think that one of the ways, especially with the bispecifics, that these myeloma cells, they're still cancer cells, so they're smart, they're constantly trying to figure out how to survive, is if you're constantly, every week or every month, hitting that BCMA, the myeloma cell will figure out how to get rid of the BCMA or change the BCMA. And so we're working, this is this concept of selective pressure. And I think I'm close to wrapping up here. We have a lot of targets and a lot of new drugs, CD38 with Darzalex or daratumab or Faspro, isatuximab, SLAM-F7 is targeted by implicity, BCMA, many targets, GPRC, 5D. I haven't even mentioned FcRH5, which is another target. What's good is that every myeloma patient, no matter what their risk is, likely has needs. So all patients are going to be eligible. And what we're going to spend the next 5 and 10 years figuring out is do you do this first or this first? And why, the question is, why are we waiting until the 5th line of therapy? Why am I not getting it now? So those are all the questions that we're going to be asking. And so if you really want to see what we believe our future is, it's on this slide. We are currently developing this protocol. And this protocol says every single drug that I've shown you in the past 40 minutes or so, we're giving, and we're giving in 2 years. And we are going to say, we now have the tools to cure myeloma. And so we're going to develop studies like this to that end. And my last slide is this is all the folks doing the work. You see these folks over here, myself and Dr. Nuka and Dr. Joseph, we're clinical and clinical research focused. The folks in the middle, both are clinical as well as doing a lot of laboratory and translational research, and the folks on the other side are our scientists who are feeding us the next group of things to hopefully make everybody better. And with that, I'd like to thank everybody for their attention, and I'd be happy to answer any questions.
Thank you, Dr. Kaufman. And as he just stole my thunder, we'd like to raise some questions if you have, and we'll take them from the floor.
Yes.
What's the longest study that has been done for
What's
the longest survival rate of remission for somebody that's had?
So right, I showed you the most updated data from the Siltazol study shows that the average survival is right around, the average, how long the myeloma stayed quiet is just under 3 years. So if I go back to that slide, and this is right at 4 years, 60% of patients in this study, about 100 patients, are alive 4 years after the treatment. Yes? Hi.
I've been in remission for 13 years.
Amazing. You must have a great doctor.
So, if I relapse, what, I can't wait.
So, okay, but we don't have, like, so I can't, and so right now, I'm not gonna, we're not, I don't know if we can answer that question, but this is what we have. I'm sorry about this, how people's, like, we look at this for you, and we gather all this information. You know, we're sort of doing this constantly. And then we say, here's what we have available today. Now, 5 years from now, 10 years from now, whenever it is, and maybe never, where all the CAR T cells that were done in 5th line, they've had 3 or 4 prior therapies, are moving up, and the bispecifics are moving up. And so it's very likely sometime in the near future that when patients, their first relapse, we're going to be having the CAR T cell conversation then, or the bispecific conversation then, or some combination then. So, but right now, it's these 2 slides. We do this, and then we look at this. Yes?
I have a multiple myeloma. I was diagnosed on 2018. I have a bone marrow transplant in 2019. I was diagnosed on 2018. I relapsed this year. I was maintenance with Revlimid, but my doctor told me I have to do the immunotherapy treatment. He said he think he's gonna work on me, but I'm since June, and like on August he told me it's not working. The treatment is not working. I'm gonna have a bone marrow transplant, but I didn't finish my treatment yet. I'm a little, confused about that.
Let me try to summarize. You had diagnosed in 2018, transplant in 2019, and you were on Revlimid as maintenance.
Right.
And then the myeloma got worse this year.
This year.
And you've started a new treatment, and it's not doing everything that we want it to do, or
Well, the doctor told me the new immunotherapy is the treatment I'm taking right now is gonna work. But he told me just last month he's not working.
Yeah.
And I need the bone marrow transplant.
yeah, I think so. I think anytime we recommend a therapy, we're obviously very hopeful it will work, but we can't guarantee. Even a therapy that has a 95% chance of working, by definition, 1 in 20 people, it's not going to work. And so I think being hopeful that you would respond to next line of therapy, I think is very reasonable. Unfortunately, we can't guarantee. So where I consider doing a second transplant is in patients who've had at least a 3-year benefit from their first transplant, and it seems like you had that, and are responding to what I've done next. So so my general approach is to consider a second transplant in myeloma that was in remission for at least 3 years, and then getting benefit from the next line of therapy. If you're not getting benefit from this next line of therapy, I would consider another line of therapy.
Maybe the CAR T cells?
CAR T cells currently are not available in this setting outside of a clinical trial. I can't answer like what I would do for you like right now, but that's been my general approach to thinking about second transplants. So, but the thing about second transplants is, on average, they work for about half as long as the first transplant.
Oh, really?
Right. So it's unusual to get another 3 years out of it. And so if the benefit that you're, so that's why even a year and a half average benefit is probably, if there's other options I'm choosing other options. Even though I would consider it for somebody who had a 3-year remission, I'm more considering it for those patients who had 5, 7, and 9-year remissions. Because if you've had a 5-year remission, then on average you're going to get a 2.5-year. And the problem with a 1.5-year remission is, we all know it takes at least 6 months to fully recover from transplant. And then you start, the benefit of the transplant somewhat narrows.
Okay, thank you, doctor.
Yes, sir.
Today, I did a version where I had a stem cell transplant in 2015.
Great.
What defines being in remission? Because after I got out of there on Halloween, in May 1st, I started going regular.
Yeah.
I was on it for about 3 or 4 years. Was I considered in remission?
Yeah. So that's a great question. I say the word remission, even though we in myeloma actually don't define the word remission. And so remission means the myeloma. So broadly speaking, remission means the myeloma is under control. So what we define very, very carefully is level of response. So anybody who's responding, or who has responded to a transplant, even if you're on maintenance therapy, even if you haven't had a complete response, or an MRD negative complete response, or whatever, I consider that person in remission, as long as the myeloma is under control at whatever level. That, in my definition, is remission. So you have been in remission, and you were in remission 3 months after transplant. You probably were in remission going into transplant, which is our standard. Yeah. We have a bunch of folks. We'll just go side to side here. Go right here. Yes.
Generally, why
Or here.
why are treatments after remission from Revlimid, why do they last for a shorter period of time than Revlimid, or do you see future treatments lasting longer than Revlimid?
Yeah. So it's a great question, and that's sort of one of the standard slides that I have sometimes. Is that one of the things that we see in myeloma is that every subsequent remission is shorter than the last one. Why that happens, because the myeloma becomes smarter, figures out how to, the myeloma that's left behind that came back was the myeloma we didn't kill in the first place, so it's a little bit tougher, and the myeloma comes back a second time, is the myeloma we didn't kill in the first place, a little bit tougher. But I will tell you that that's why when I mentioned that I think we're stepping into a new era, is that CAR T cells and bispecifics, the average remission duration from CAR T cells and bispecifics is longer than the prior remission. So it breaks that thing, because the more effective therapies we have, the less that what you just mentioned occurs.
Thank you.
Okay, I'm gonna go right here. Yes, ma'am.
Hi, I was diagnosed with myeloma in January of 2022, and I had a stem cell transplant in July of 2022. And I went back for my year, but I still, by my doctors, she said I still have not reached remission, but they stated that in my bone marrow biopsies, they didn't see any myeloma.
Right.
So, but she
when they say you're not in complete remission, what they're saying is your level of response. And so it sounds to me like what you're describing is that you have not had what's called a complete response. And so if we take 100 or 1,000 patients with myeloma who have had a complete response, that group of 1,000 patients on average will stay in remission longer than the group of 1,000 patients on average who didn't have a complete response. But that doesn't say anything about you. And so we know on an average, people who've had a complete response do better than those who haven't. But I have patients who've had short remissions who've had a complete response, and I have patients who've had long remissions who haven't had a complete response. So in a large part, we don't make decisions based on what you're describing. The recommendation is, our recommendation would be on our best maintenance that you can be, and hopefully that remission lasts a long time. Okay, I'll go here. Yes, ma'am.
How does age impact these newer treatments? Specifically,
Yeah.
my person I'm a caregiver is 85 and is recently diagnosed.
Right.
So do you consider that with the comorbidities?
Yeah, so age in and of itself doesn't impact things, but those patients that are older are more likely to have all the other things that really do impact things, which is other illnesses, what we call comorbidities, functional status, overall activity level, risk of toxicities. And so for example, for those patients who are in their 80s, we typically wouldn't give the 4-drug treatment regimen, we'd give a 3-drug treatment regimen.
And that's what she got.
Right, which would be totally appropriate, which is completely appropriate. And in a large part, the decision to do CAR T cells and bispecifics will be solely dependent on all the other stuff and not the age. But the age makes all that other stuff, which makes getting those harder treatments harder to do, more likely. Okay, yes?
So I was diagnosed in March, and as you know, I had my transplant in July, and I just had my PET scan and my bone marrow, and I haven't met with anybody.
You don't want to look it up.
What? Yes, please. For what I read now in my chart, it seems everything fine.
Good. You probably, like I said, you have the information before I have the information.
Yeah. So it's like everything fine. So what I understand the next step for me is next week, Europe is confirmed that line. Is that I'm gonna have maintenance treatment?
Right.
Is that chemo and what?
So the most common maintenance therapy we use is Revlimid as a single agent.
And that's
Revlimid, so
that's for like so long usually.
So it's a great question. We use it. We start at 10 milligrams, which is lower than the standard dose. We do it for 3 out of 4 weeks. The studies that were associated with people living longer, because people live longer on Revlimid maintenance, treated patients as long as it was working and as it was tolerated. One of the things that we're developing now is monitoring, and I didn't talk about what we call MRD at all, and I don't want to get into it now, but we're monitoring very, very tiny levels of myeloma in the body, and we're developing a strategy that if patients are MRD negative at 2 years after transplant and 3 years after transplant, then we're talking about stopping Revlimid. And there's a lot of people that stop. There's some people that stop Revlimid just at 2 years or 3 years without that assessment. But in our recommendations is as tolerated, typically 3 years at a minimum. 3 years from transplant.
What type of meat?
That's okay. Let me just get this one first.
Mine was just.
Oh, okay. We'll get you in a minute. You go. Yeah.
With all the different types of myeloma, each one of us has a different
Yeah.
myeloma, and the new therapies that are coming out, is cure
that's that last slide I showed you. The second to last slide I showed you was our attempt to be cured.
But I mean, cured where it doesn't come back after a few years?
That's our hope. That's what we're doing.
Still a hope, but not a promise yet. You know that's right.
You've known me long enough.
I'm
Yes.
gonna keep trying.
Yes. Yes, ma'am.
I had a bone marrow transplant April of this year, outpacing with Dr. Lonio.
Okay.
I just wanted to thank you because you came and checked on me the entire 2 weeks I was in the hospital.
Yeah, it's great to see you again. You look great.
I appreciate you.
We appreciate you. You look great.
You know, can I add on that, Dr. Kaufman, you did my very first bone marrow biopsy at Youri.
Oh my goodness.
And it's 20 years later, and I don't care, so thank you.
Your question, maintenance for non-transplant.
No,
Oh.
treatments for patients that can't tolerate Revlimid.
Oh, that's a very difficult, so sometimes we use Velcade and those types of drugs. Sometimes we use daratumab if you can't tolerate Revlimid. Okay. We have one more. Yeah, a few minutes. We'll do one more. Yes, sir. This will be our last one. Yes, sir.
I want to know what the benefit is of an early stem cell transplant. Somebody wanting remission in that remission period versus somebody that just takes
Right. Great question.
treatment in their remission period.
Yeah. There was a
Versus somebody that has a later stem cell
Yeah, I understand.
transplant, like maybe 3 years.
Yeah. So if you look at we've asked this question many times over the past 30 years since transplant was first shown to be effective. And every study shows the same exact thing, which is early transplant is associated with staying in remission longer than not. So the most recent study, that remission, the average remission duration ended up being almost 2 years difference. Staying in remission, almost 2 years longer. I think a better way to look at it is maybe look at the percentage of patients who remain in remission, 5 years later. It's probably the difference between 50% and 30%. So 20 to 30%. So there's clearly benefit. But we also, in all these studies, also show the same thing, that if you do the transplant later, you don't lose any benefit from how long you'll ultimately live. So we say delaying transplant is not associated with a decrease in how long you'll live, what we call survival. But there's a clear benefit across the population of patients that it keeps people in remission longer. What I have found in a large part, if a patient makes the decision, if we make the recommendation, we think you need a transplant, a patient makes the decision, I don't want to do a transplant now, it ends up not being transplant later, it ends up being transplant never. And because what happens is, you said, well, I did pretty good the first time, why can't you just, now we have all these fancy new drugs, why don't we just do this and not do a transplant? So that's my impression, and that's happening. The more and more we have better therapies later, the less and less a delayed transplant ever becomes a delayed transplant. It becomes a never transplant. And the reality is, we know that transplant still works. And so from my perspective, in a young, healthy person, why would we not do something that we know works? So that, yes, sir.
Where would I find the study with that data?
The New England Journal of Medicine. It's called the endurance. Now I can't remember. I should know that because I'm on the study. It's not the endurance study. Determination. It's called Determination. And if you look myself up and Dr. Loniel and Determination in New England Journal of Medicine, you should find it. I have it on my computer too, I could show it. I think we're done. I'm getting kicked off.
off by any means. I just want to be respectful of time, of everybody's time, and close the session. Dr. Kaufman will be around if you'd like to approach him individually to answer some questions. But can we give him another round of applause for that? So this concludes our question and answer portion of the presentation, and I invite you to visit our patient community outreach booth located in the exhibitor hall, where we have one of our information specialists managing the booth to be able to answer any questions and provide information on resources and other LLS programs available from our national office. Lastly, we have a program evaluation. You should have received this evaluation when you checked in this morning. Please take a moment to complete the evaluation because your comments are really critically important in helping us make sure that this conference meets your needs. And again, a big thank you to Dr. Kaufman for being our speaker. This concludes our conference today, and thank you for joining us. It was wonderful to have you.